don't wake
Good
up.
morning, everybody. This is Dr. Gabriele Jasper, the best co-host in the world, Jeremy Vickers.
Yeah. Thank you. Thank you.
All right. So today, I'm MD. I always like to announce exactly what I do. I'm an interventional pain physician.
Yeah.
I do interventional pain.
Your mic, doctor.
Sorry about that.
Yeah.
I got to talk into the microphone.
It's a live show.
That's
It
right.
happens.
Well, I figured a lot of people read lips today. Read my lips.
Read my lips.
Interventional pain. What is interventional pain? Now, this is my opinion. Interventional pain is a super specialty that will get rid of pain based on locating and finding the pain generator.
Mm.
And that's what we master. And we do that we get rid of the pain by getting rid of the pain generator, taking it out or moving it,
Right.
or make less pain generator, which can ultimately be no pain. I don't know if I said that right, but
Yeah. No,
the point is, we do interventional pain. We use instruments and procedures to get rid of the pain. We do not prescribe pain medication. The only time I prescribe a pain medication, if I do a procedure on you that might cause you to have pain for a few days. And believe me, I'll only give you a couple days worth of pain medicine. Anyway, there are a lot of other pain doctors that do pain medicine. They call it pain doctor, pain medicine.
Pain management.
Or pain management.
Yeah.
They do some procedures, but not the procedures that we do, that I do. And I always tell everybody the fact that I don't want to send patients for big surgeries, especially if they're unnecessary.
Right.
I do send people for surgery when they're necessary. And the doctor needs to understand when and when not to send these patients. And they also need to trust the surgeons. I have now some surgeons that I deal with that are very trustworthy, and I don't worry about them doing unnecessary surgery. You got to understand who they are.
Yeah, Dr. Mike Katchmar said sometimes for the doctor, it's not enough to know what to do or what should be done, but sometimes you need to know when not to do something.
Yeah, I mean, and that's important. It's important, and not that a lot of these guys are dishonest.
Right.
Some of them have been trained and brainwashed that the only way to do this is with a fusion, even though fusion is not indicated, in my opinion.
Right.
And everybody has their own opinion. And the consequences of a major surgery, if it turns out bad, is not good.
Now, with the new flush of young doctors coming out of medical schools now, right?
Would you call that the what?
The flush of
flush?
Yeah.
It don't sound too good.
No, it doesn't. But
because there's not too many graduating. It's really going to be a major shortage of doctors. But go ahead.
Well, I just wondering if you see in the future this kind of, do you see these doctors going forward or staying behind, like these in quotes pain management that don't want to go any farther? They're comfortable with what they got. Do you see this problem continuing into the future with the new doctors coming out of med school?
Well, there's very few neuro or orthopedic spine surgical residency and fellowship training at this point that are teaching these new things.
Right.
They don't teach them. I don't understand why. And I'll keep telling you this. This is the most backward country in the world when it comes to spine surgery. And everybody listen to this.
Yeah.
If I need spine surgery, I think I'm going to Korea because they are more advanced than anybody right now.
Yeah.
They don't mess around. And one of the reasons is because it's socialized medicine. And I'm not a fan of socialized medicine except when it comes to this topic.
Right.
And I've said this before, because some people get weak and they go for the money.
Mm.
And I'm talking way from the top, the CEOs of the insurance companies, all the way down to the companies that sell the instruments,
right,
and everybody else in between. So when you go to somewhere like Korea, Europe, socialized countries, if they get paid the same amount to do a big, gigantic spine surgery with fusion, choose between that or do a minimally invasive procedure that's what you're supposed to do.
Yeah.
Guess what? There's no money motivation, and they do what's supposed to be done.
Yeah.
You know, but I even do procedures now that has not really hit Europe yet. They're
Right.
all invented, in Germany, but in different countries, but they're hitting here with the interventional pain docs because they're minimally invasive, and we got through them. And maybe I'll go through some of them today.
I'm dealing with
That works.
I'm dealing with socialized medicine in the hospitals over in England because
Yeah.
my dad's not doing too good, and it's like it's night and day different, And they like to say that, oh no, we take care of everything, it's free, we'll take care of you. It's not free.
Hey, listen, you know the old saying?
What?
You get what you pay for.
You get what you pay for, yeah. But see, it's not free. It still comes down to money, and I got them to say that to me. And I'm like, so what's the big deal? I actually said this to one of the doctors. I said, what's the big deal about socialized medicine? Everybody's like, oh, this is great. This is great. If it just comes down to the money, like anywhere else in the world. And he's, I know. That's just how it is. They just accept it. They just accept it.
Socialized medicine.
Yeah.
It doesn't help patients to a certain extent. They put them on budgets as far as, you reach a certain age and you can't have certain things done.
Yeah.
When the government controls your future in medicine, that's not good.
That's it. Yeah.
It has to be controlled by the physicians, honest physicians, and patients. The physician we are here to make a complete history, physical examination, come up with a diagnosis and treatment plan. Not to be blocked by insurance companies and say, you can't do that. It's experimental, where there is no way in the world. It's experimental. It's been proven. FDA. Listen, if the FDA approves it, it's not experimental.
Right.
Unless they approve it through a study program where you're actually doing it, and they're doing prospective, retrospective studies, double-blind studies, to prove that it works. Guess what? It's easier to do a procedure that is under that realm of experimental practice, doing experiments and studies, than some of them that are out there have been proven.
Right.
If I said that right.
Yeah, no, I got you. Yeah.
But you mentioned about the doctors coming out. I have a practice and have a very, very busy practice.
Right.
And I'm one person. So patients wait. They got to wait. They like to wait. They don't like to wait, but they wait because they know they're going to be treated well. And I'm going to treat them, and I'm going to do the right thing, and they're going to feel good.
Yeah.
I'm pretty good at what I do, and my reputation proves that. The problem is I need help. I like to get somebody young or older, doesn't matter, that would help me. But I need to get somebody that's going to work on what they actually bring in.
Right.
I listen. I'll if anybody's out there that's interested, I do the advertising. I take care of all the overhead,
Right.
and then a person should come in and work. And I get them a lot of patients, and they got to step up to the plate and get their own patients too.
Yeah.
I just said that backwards. They got to step up to the plate and get their own patients.
Patients too. Yeah.
No, I said step up to the pace and get their own patients. Anyway, but and then whatever the overhead is, we figure it out and subtract it, and you get what you eat, what you kill, basically.
Right.
And
that's a good way of putting it.
And you got to have an open mind. You got to be somebody who is into this minimally invasive procedures.
Got to work.
Yeah, that'll work.
You got to work. You got to do your work. You got to
have a good personality. You got to be sociable. You got to know the rite of passage.
Right.
You got to be humble. This is how I've always been.
You got to have a passion.
Yeah. Oh yeah.
too.
Right.
I mean, the passion is big.
Yeah.
That you need.
And believe me, the patients, they respect that, and they're very grateful.
Yeah.
You know, every once in a while you get to your assholes, but that happens no matter what it is.
Yeah.
So if anybody's out there that's interested, you know, contact me. You know, you can call me directly. You know, I'm on social media. You can call us, you know, patients or physicians that are interested.
Yeah.
You can call me at 732-262-0700.
A surgical center and everything, right?
Yeah, 732-262-0700. I mean, even if you're out of state listening to my podcast, you want to come to the Jersey Shore, which is a great place to live. I live on the water.
Right.
I love it. In fact, today, I'm probably going to go clamming.
Oh yeah.
And then we'll have some nice linguine with clam sauce. I'll put the crab traps out.
Huh.
And I'll have, by the time I come back from clamming, I have at least 10, 15 crabs in there.
Oh man.
So I'll make one of those linguine with crabs, and maybe we'll throw some calamari in there. I might have to buy some of the calamari.
Yeah, yeah.
But anyway, it's a great place to live.
Mhm.
Schools are great. And you can contact me. You know, Jasper Spine Institute. What's the email?
It's jaspermd.com.
That's right.
Yeah.
You could email us there with your credentials
Mhm.
and work something out. Come in for an interview. It'd be great. You know,
Right.
we can. You know, the main reason also is the fact that, you know, I got to take a vacation once in a while.
Sure.
I got over 25 employees,
Yeah.
and when I'm the only one working, then when I'm not there, the practice doesn't make money. Who's going to pay the salaries? You know.
Right.
Yeah, I'm also interested in maybe a nurse practitioner or a PA.
Mhm.
If it's a PA that's seriously interested in learning interventional pain, or somebody's got experience, that would be good too.
Yeah.
You know, because I could step out of the office and a PA could do certain things. And if they're good and they have the ambition, you know, I could teach them a lot.
Right.
And they're allowed to do procedures, you know, so that would be a good thing too. Might be better,
Right.
you know. But anyway, talking about these minimally invasive spine surgeries, I had a patient came in yesterday, was 80 years old.
Mm.
You know, we did certain procedures on him and he did okay. But he had that low back pain that, you know, you really can't sit for a long period of time. You can't stand up. You could stand up because I've usually fixed that. But even standing up, sitting down, bending over, picking something up, a typical pain you get from the low back, it's called discogenic pain. And one of the things that we've done, in fact, there was somebody who might be listening now that is from Washington State. They want to come, but we don't take their insurance. They want to pay their own money to do it. It's very expensive if you pay it.
Right. Right.
But I'm trying to work out a deal with Biodisc for the company that it's actually an allograft that goes in the center of the disc that is broken down.
Right.
Because the center of the disc breaks down, the nucleus, which is this red part, breaks down. And that's the major shock absorbing effect of the spine. I talked about this, but I want to reiterate it because this guy yesterday came back 100% pain free. Who does that? You know, it's like, is it magic? I don't think so. I was very skeptical in the beginning. So were most of my patients when I started telling them about, we get this, somebody donates to Body to Science anywhere from 15 to 55 years old.
Right.
The company actually that produces it, they retrieve it, they process it down to like 300 microgram powdered form. They send it to me. We instill it with some normal saline and we inject it into the spine, not the spine, but into the center of the disc. And it's got to be precision right into the center of this, which isn't hard for me. And I put it in. It's a short, easy procedure, one level at a time, because they only pay for one level because it's expensive.
Right.
And another reason why I pay for one level, they only do one level, is because I've done one level, somebody's 5 levels, and they were good.
Right. Right.
So why would you do all levels? I did somebody 5 levels, 3 levels, good.
Yeah.
You know, they say, listen, I feel great. Can I cancel the next one? Absolutely.
You don't do more than you need to do.
That's my philosophy.
Yeah.
You know, little's always better.
Yeah.
And that works very, very well for that type of pain. So if you got low back pain, you've had injections, you've had surgery, as long as you have, I have access to your disc, which 99% of the time I do, and you know you have degenerative disc disease, you come to see us. 732-262-0700. You come to see us, and I will fix that part of your disc. You know, listen, the jury's not out exactly what the future is as far as how your discs are going to look and be, but they've already proven that by doing follow-up MRIs like a year later, that the disc almost looks like an original good disc. In other words, it's all lit up the center. See, when the discs are black, that's degenerative.
Yeah.
The darker they are, the more degenerative. Plus, you start to lose height. Some of them are completely fused and gone. I know you can't; those you can't do. But if you could put it in there, it'll absorb some of your own fluid,
Hmm.
physiologic fluid, and plump it up to a certain point.
Really?
Now, if you think about it, technically, that should stop the degenerative disc disease in its place.
Right.
Like, you're done. All right, you're not degenerate. With time, you live long enough, it might happen again. But either that or it slows it down tremendously.
Yeah.
And that's my opinion. I mean, they talk about that, but you need many years, and this is relatively new, within the last year or so, 2 years maybe. Time flies, and so it slows it down. So, as one of my lectures here talked about, how when you have degenerative disc disease, that brings upon everything that you have in your spine.
Right.
But if you could stop that, it'll stop the progression of everything. But the downside of this is Medicare is the only one paying for it. If Medicare pays for it, it's a proven procedure. But the insurance companies look for any reason not to pay for it. And it's been proven. Why aren't they paying for it? Well, because they don't want to spend the money, because it works so well that they're going to be spending a lot of money to help people. I don't think they want to do that.
Right.
It will increase the amount of money insurance companies have to pay tenfold probably for these patients that have it. Because in my opinion, somebody comes to my office at 35 years old that was an ex-football player that has one bad level and the rest is still pretty good because they injured themselves, and has that one black disc and starting with problems. They are more of a perfect candidate for that procedure because you're catching it early.
Right.
And that's when you really see what the future will bring.
Yeah.
I mean, that could be the future of people who somebody starts with degenerative disc disease, put an allograft in them.
Right.
And I bet you that they either don't have a problem, or it's many, many, many years later.
Yeah.
They become more like a normal person.
This sounds like a game changer.
Well, I think it is. Like I said, I'm skeptical. However, it proves it to me. I've done probably pushing 100 of them already.
Have you really? 100?
Yeah.
Wow.
And everybody, I have never had somebody that said that I did not get better. I think the worst patient got 40% better. I mean, 40% better.
That's
you
a
get
result.
In
That's great.
Pain, yeah. They come in on 40% better. Probably half of those will say, "I'm good, doc. Thanks. I don't need you anymore."
Yeah.
So that's pretty good.
That's brilliant. That's brilliant.
And
see, Dr. Jasper never stops looking for new procedures for his patients. He has to vet them out, and they have to work. But he's constantly looking for new procedures to eliminate your pain. It's brilliant.
Well, you know what? I don't even have to look.
They come to you.
They come to me.
Yeah.
And believe me, there's been a few people, I don't throw them out of the office, but I say, "Thank you very much. I appreciate it. But if you have a better device, next time you bring that one, I'm not satisfied with that." Because sometimes you see these things and you say, "There's no way they're going to work." The one with the Viadisc, I mean, if you think about how it works, it looked like something that could work. But it seemed a little bit far-fetched.
Right.
How could that be so simple to work? But it works.
Yeah.
But they come out with some devices how you put it in, it's not minimally invasive. They tell you it is, but it isn't. And just the mechanism on the physics behind it, you say that's really not going to do anything for the patient.
Right.
So I'm not even going to try it.
Yeah.
And there's not that many studies. Now that's something like that is experimental. You got to prove that to me.
Yeah.
And most of the time when I do things, very rarely it hasn't been proven already. I've done stuff on patients in the past where I was probably the first person to ever do it on a human being.
Right.
Cadavers, pigs, stuff like that, because it just seemed like it was going to work well, and it worked well. But but somebody, I'm not going to mention any names, but you're talking 20 years ago, 15, 20 years ago, that these procedures were good, except they charge more for the stuff than the insurance company paid for. So boop, goes to the wayside.
Mm.
How could you expect a doctor to do something when they got to take their money out of their own pocket to do it?
Right.
That ain't gonna happen. They can't afford it. And you're working on the spine, and when you're working on the spine, that increases the risk of bad stuff happening. Not that it happens often,
Right.
but you don't want to work on a spine and pay out of your pocket for a risky thing that could turn out bad.
Right.
Even if you do everything perfectly okay.
Yeah, you gotta cover your ass just like anybody else. Yeah.
Well, anyway, you notice that shirt I got on here today? I got the Passaic County, not the Passaic Police
Emergency Response Team.
I like to put out a shout to them.
Yeah.
Thank you for responding. And the reason why I have this is because I was actually raised in Passaic.
Mm-hmm.
I went to Passaic school systems and graduated from Passaic High School. And I can't believe that if anybody from my graduation class is here, they're probably upset with me because I couldn't wait to go to the 50th reunion, which was 2 weeks ago.
Was it really?
It was 2 weeks ago, and I had it on my calendar. Like a week before, somebody called me up, texted me, and said, "Don't forget." I said, "Believe me, I'm not going to forget. I will be there." In the meantime, Don and Felix invited us to the Pennsylvania. And we're sitting there, and I get this phone call. I got a Saturday night phone call, text message. "Where are you? We're waiting for you. Why are you so late?" I was like, "Holy shit!" I was like 3.5 hours away.
Right.
And I wasn't in any condition to be driving 3.5 hours.
Sure.
So a little guy get upset about that. Hey, listen, when you go to people that go to the 50th high school reunion, forget things.
Right.
You're at the age of starting to forget things.
Yeah.
Well, I was always like that. A lot of stuff you forget, even if you're not senile.
Oh, I'm 50 now, and I'm forgetting all kinds of stuff.
Yeah.
Yeah.
But too bad I missed that. Well, I'll just wait for the next 50th.
I haven't made it to any reunion yet. I've seen the pictures, but it was always something. Life gets in the way sometimes.
Well, I make it a point to do that. I always have. Anytime they had it, I was there. And this was like probably the biggest and the most important one. Next one's 100 years reunion, but I don't know how many people will be around.
No, well, you will be.
Yeah.
Yeah.
Anyway, so that's good. So we talked about, we're always talking about the same stuff most of the time because it's just so good.
Yeah.
So good. My endoscopic procedure, I've been doing, and I did one on you recently. You had foot drop, and your foot drop is getting better.
Mm-hmm.
It might have taken a major hit, and
I don't think we've even talked about this yet on the radio.
No, tell me how it happened.
Well, him. I woke up on a Monday and
switch this to you.
Oh, hang on a second.
Oh, you can't do that?
No, I can. I just wasn't prepared to.
Well, you can't be ill prepared.
You're right about that, Doug. Is that on? Anyways, there we go.
Oh yeah, that's very, very professional right there. Just
you don't think
switch the camera around. You should hire somebody now to do it.
So it was all custom. I woke up and my foot just stopped working. It just became a drop foot. I had no pain. That was the crazy thing to me anyway. I had no pain at all, but I couldn't lift my foot. And it was numb and all of that. So what happened on a Monday? So I went in to see the doc on Wednesday. Man,
you probably should have come in on a Monday and we should operate.
I really should have. I didn't know what it was. I actually thought I might have slept on it wrong or something. So, you
didn't really have pain, did you?
No, I had no pain. Zero.
That's weird. Usually you have pain first, and if it's bad enough, the pain might go away.
Yeah. So I went into Jasper Spine Institute like anybody else, and the nurses just came rushing into me and testing me out, testing my reflexes, this and that. And Doc takes this stuff so serious. If you got drop foot, you got to act right away because, otherwise it could go, worse for you. So he scheduled me like the very next day.
Yeah, Thursday, right?
Yeah. Oh yeah. Yeah. He even got me. He even got me into an MRI when the earliest I could have gone on, scheduled on my own was like 3 weeks away. But Dr. Jasper, figures it out, and I'm in there in an hour.
Well, it's not me. I give that assignment to the front desk,
Yeah.
and when I do that, they're pretty good at it. They do 2 or 3 of them a week,
Right.
and you're not the only one that had foot drop all of a sudden that week.
Yeah. Well, I I was brought in. I had the endoscopic discectomy and it was amazing. Like you're all covered up while Dr. Jasper's doing this procedure, and I had Dr. Conwin as my anesthesiologist. I think he's brilliant. He's the best I've had anyway, and so I'm not feeling anything. I'm laying on the bed on the table, and Dr. Jasper's working at it, and I move some of the stuff that's covering me away from my face so I could look up at the screen and watch what he's doing and that, and it's amazing what Dr. Jasper does. My area down there was all filled with scar tissue, and it was a mess. It's like a messy room, and he's got to find like the one Matchbox car Lego piece,
the one clean underwear,
right?
in a messy room.
but look, I mean, he's brilliant. He's the only one I trust, only one, and I've told people I would trust him with my life. He's the only doctor I would allow to touch and work on my back, and it's better. It's so much better. I'm walking better. I'm able to lift up my foot better. It's still a little numb, but I think my nerves got a lot of healing to do still, and but it's brilliant. And a lot of patients, and I talk to a lot of patients. They recognize me from this show or from the TV commercials, and they're always worried about the pain, or when you're living through pain. This was what it was like for me. When I lived through pain, you understand the pain you have, but you're terrified of any new pain that you don't know. And let me just tell you, this procedure was, for me, painless. There was just a mild sensitivity in the back, but that went away pretty fast. And then you're back on your feet again, and it's amazing, and you wonder what you were worrying about.
Well, if most spine surgeons would have, especially the fact that you already had a hemilaminectomy in that area,
Yeah.
and you've had multiple endoscopic surgeries in different areas of your spine, and you don't have the greatest spine in the world, and it almost comes down to, they said, "Oh, you did this, this, and this. Now we have to do a fusion.
Yeah.
We have to do a fusion. We have to do a fusion." And my father used to get so pissed off when I used to talk negative about these fusions, because he doesn't want me to say bad things about any doctor.
Right.
Well, I'm not saying anything specifically bad about any doctors, but look, you're living proof. I have patients out there now that a young, great woman that's like in her 40s, and I've operated on her multiple times, and I feel so bad for her. She's an athletic woman. She's a hard worker, and right now for like 8 weeks she's been in bed, and she's had multiple procedures done, and I think ultimately she's going to do okay, and she does okay. But then something else pops up. She's been cursed with a terrible back. I don't know where the heck it's coming from. It's probably she's lacking some genetic gene that maintains her spine.
Right.
And I don't think we are capable today of finding what that gene is, because what it is probably some enzyme that your body produces, or protein or something that the body produces to prevent That's why you have people with degenerative disc disease more than other people. And their parents had it, their grandparents had it.
Mm.
Their parents were in a wheelchair at 50 years old or 60 years old, whereas now they're my patients, and I try to avoid that, and the job's hard. It's
Yeah.
tough. And most of the patients that have gone for the big major surgeries, that doesn't make it really doesn't make it better. It's and I had a patient that was similar to this patient here, and he had foot drop, and there was nothing I could do to get rid of the foot drop. And I got rid of it, most of his pain, endoscopically. I put in some spacers, stuff like that. I did okay, but the guy was, he wanted to be perfect.
Yeah.
And like, you will never be perfect.
Right.
People with backs like that, they got to come to terms with it. Like me with my neck, I came to terms with it.
When you first fixed me, that's what you said. You said, you got degenerative disc disease. So you're always going to have this. He says, so you're going to have to continue to be careful.
Yeah.
Yeah. No, you said that to me right after the first time you fixed me.
And then I didn't know what to do, so I talked to Dr. Radcliffe.
Oh yeah,
and he looked at him, and he figured out a way to operate on him, and he did a fantastic job.
Did he really?
Dr.
Radcliffe is awesome.
Except the patient still has pain.
Really?
Still has pain, and he did a great job. I looked at the surgery. He didn't overdo. It wasn't overkill, but sometimes people just don't get better.
Yeah.
And it's hard for me to say give up. That's my biggest problem, is I don't want to give up.
No.
And I speak to the surgeons. I speak to Dr. Radcliffe together. We're trying to come up with two heads are better than one. Two honest heads, like he's an honest guy.
Yeah.
He doesn't want to do unnecessary stuff. But sometimes you got to bite the bullet and do a fusion. And he did. And listen, it could be the guy's personality too.
Really?
It could be the guy's personality where, every little, if you really nitpick the pain that he has, he's better.
Right.
But that foot drop just never went away. And I freed it up, which should have been enough. And then I said, well, maybe there's something in there. We don't see it through the MRI. So he freed it up.
Yeah.
The foot's dead. The nerve is dead. So at that point, when somebody has a foot drop, you have to tell them, and every surgeon tells them this, we're going to operate. The best scenario is a foot drop comes back and goes away, and you start walking normally. But the idea now is to stop it from getting worse.
Right.
Maybe get a little bit better, because you never know what direction it's going to go. Once you have, I've had people foot drop for a year. I go and operate, and it goes away. Right. I've had people like you had foot drop for like 3 days,
right,
and it has not gone away yet. It's gotten better.
It's gotten better, but yeah.
And I've had people have foot drop for a week, 2 weeks, never even got better.
Yeah.
And it's not.
I'm as a patient, I'm very aware that one day it might not get better anymore.
Yeah.
And and I got a weak knee on that leg. I actually favor my left leg. I'm a right hand, but it's called cross something. But I favor my right leg. I kicked with it. I always, I start off with my left leg.
So left leg?
Yeah. So, it's a learning process, but I've gotten used to adapting, to this or that, a limp or that over the span of my injuries, but I am aware. It's you can only fight long enough, and then the damage that's been done in the past, I get it. It's sometimes you just
people don't realize that, all right, major surgery leaves scar tissue, and everybody knows that.
Yeah.
Endoscopic surgery, listen, you muck around in there a little bit, there might be a little scar tissue, but very little.
Right.
Like I've done multiple on you.
Mm-hmm.
And there's a little bit of scar tissue in there, but nothing crazy like a big surgery.
Yeah.
And you actually have scar tissue from the original surgery.
Right.
So yours is a little tough. But what leaves the scar tissue is this chronic inflammation that people have.
Yeah.
You know, constantly getting inflamed. The body goes in there, tries to get rid of whatever's inflamed, and lays down tissue, comes in to try to heal it over and over and over with somebody back pain, leg pain, intermittent sciatica pain. And after a while, that leaves scar tissue in itself.
Right.
So you got to deal with that stuff. And there's nothing better than direct visualization with an endoscope, because you're looking at something that's maybe the whole diameter, whole space that you're looking at is maybe half an inch total, maybe an inch big, but you're looking at it, something's like 10 inches on a monitor,
Right.
on a big screen, 10, 20, a foot, like 12 inches.
Yeah, it's amazing.
It's like 12 times bigger,
Yeah. I mean, I've seen the instruments that you used on me. Like you got a similar one right there. And you realize just how small it is. But when you look at it up on that giant monitor that you have, it's really amazing. And no wonder you can do this job so clean.
Yeah.
Yeah.
You still got to know the anatomy. And it takes years to know an anatomy. I've done thousands of these. And even if you do 1,000 of them, every time I get in there, there's something new. Not every time, but it's amazing how, like, I had a procedure on a friend of mine I did a few weeks back, and he started bleeding. There's not supposed to be any blood vessels at L4-5 in the trajectory that I go.
Right.
There's maybe some veins. Well, I was doing the procedure, and I was getting ready to put the scope in. Now all this blood comes pumping out. I was like, whoa, this isn't good. And these are the things that happen. You do everything perfect. You want to do it perfect. You're doing it perfect. You go, I got a protocol when I operate. I'm very predictable when I do this procedure. Once you get in there, then you manage what you have to do when you have to do it, because everybody's spine's a little different. But I couldn't even get in there with so much bleeding. No matter what we did, I tamponade and it was like we were considering going in there and looking, open them up and going for the bleeder. But it was in a position where it's on the side, you can't go posteriorly, because if you go posterior, because I was sitting in this area here, right? Which is in front of, here's the back. So in order to come in with, like a surgeon would come in this way, right? And you can't
straight
get to
on,
the bleeder.
straight on.
Yeah, straight on.
Patient laying on their belly.
Because it might be this deep, right?
Yeah. Mm-hmm.
Versus this deep.
Right.
So the incision's got to be a lot bigger to get onto that. And that, if you had to open up, that would be the right way. Because by the time you get in there, if you had this major bleeder in there, by the time you took all these bones out, the patient would probably bleed to death.
Right.
So I took all that in consideration. You got to improvise and overcome at that point.
That's an interesting point you made, though. Like, you don't have to take out any bone when you're going in the way you do.
Yeah, you don't have to take. That's why you don't have much scar tissue. But so what I did was I put the pressure. I looked at the patient's blood pressure. The systolic blood pressure was probably, I think it was like 120. So now I have to increase the pressure. This is a technique that I just developed based on what happened that day. So I figured if I increase the pressure, if there's anybody that does endoscopic surgery, this is a good thing to know.
Wow.
You increase the pressure of the fluid above 120 millimeters of mercury. Guess what? That in itself is going to tamponade the bleeder. Really? Because if you got it, and I knew it was an artery. If it's a vein, it might be 50, 60, 40. As it's coming out of a vein, so you don't have to increase the pressure that much, and it stops the bleeding. But I had it probably like 130 millimeters of mercury, and I put the scope in there, and within maybe 30 seconds, it started clearing up the blood, and I was able to start to see something, and I saw this pulsating artery, which is, it looks tremendous because it's magnified.
It's on the monitor,
On the monitor, it looks like the aorta, because it's 10, 20 times bigger.
Right.
And I'm like, whoa, there it goes. Right. And I brought the cautery in there, and I cauterized it to the point where I was able to slow it down and stop it. And then I continued the procedure, and I did the discectomy. I found the herniation, some
Yeah.
scar tissue, stuff like that. You know, the job wasn't as efficient as it would have been if it didn't have that bleeder, but
Right.
nevertheless, the patient felt better, and the foot drop's getting better. But I might have to go in there. I might have to go in there again because the foot drop is not progressing as good as. But then I gave him a shot yesterday.
They help.
I gave him a shot yesterday, and it's getting better.
Yeah, I after my surgery recently, you gave me a series of shots, and it got better because I remember before the surgery.
Series of shots.
Well, you gave me shots. Sorry, I didn't mean
Jesus
a series.
Christ, did you just say a series of
No,
shots?
not a series of 3. Anyway,
Oh,
a series of
my
1
goodness.
shot, and it does help. You gave me a shot before the surgery, and it started my foot moving again.
Yeah.
You know, but yeah, no, that's great. That's great.
So we figured that one out, and the patient and the guy went hunting in the Arctic 4 days later.
In the
Imagine
Arctic.
Canada, way up into the Arctic. They're by the North Pole with Eskimos.
That's crazy.
And he came back yesterday, and he brought us about 300 ears of corn from his backyard.
Huh.
You know, he owns a farm in up in like Long Valley, Chester, New Jersey. And he drives all the way down from that. I was introduced to him by another friend, doctor, who's also a hunter, you know, and he's become a good friend of mine. Anyway, what else? So we talked about a lot of good stuff here.
Yeah.
We didn't talk about anything funny today.
No, we had a laugh though. We're having a good time.
Yeah.
There is one thing because I you know I'm in the office and I see us trying to help patients, and sometimes they don't have the right insurance, and that's a big bit of a struggle, especially if they have Medicare disadvantage. And that is something that a lot of people don't realize they have. They think it's Medicare. And Medicare is the name Medicare is not copywritten or anything like that, or trademarked. So anybody can really use it. I can just start a company and call it Medicare, fundamentals or something like that. And but Medicare Disadvantage, you think that the doctor just sends what needs to be done to your insurance, the insurance pays for it, and then you get your procedure done. With Advantage, it goes into them, and then somebody else that you've never even met, doesn't even know your history, you're certainly not your medical history, decides whether you need it or not. And a lot of the times the answer is no. And you're still stuck and you need this procedure done. That is Medicare Disadvantage. It stinks, and you have to make a change. You have to be aware of that, especially our older viewers and listeners. You have to be aware. Realize what insurance you have and prepare, because you can hurt yourself. Doc says you can hurt yourself bearing down when you're in the bathroom or tying your shoe. You have to be prepared for these things. And Medicare Disadvantage, get rid of it. Find yourself something good that can take care of you.
Don't get me started on that Medicare.
That's why I finished it off.
The nurses try to calm me down because I actually get pissed off at the patient.
Right.
I get pissed off at the patient because two people, there were two couples, and it just so happened to be the guy, the husband, was the one that had a problem, and the wife, didn't have a problem, and it was her original insurance because maybe she was a school teacher or something, who worked for the state as a secretary, whatever the heck it was, a government, a retired official, who they put them all on that Aetna Medicare Advantage or Disadvantage, or Braven, which is Blue Cross Blue Shield Advantage, and we cannot get him approved for the Minuteman, the spacer, and he's going to do great with it. In fact, He did great about 4 years ago with the spacer, and they stopped paying for it. They were paying for it at one time. So he needs another one. He wants it because he knows how good he did, because he needed two, but he was doing okay with just one. Now he needs the second one because the one I put in is still good.
Mm.
You know, and it'd probably stay good for the rest of his life. But now the other one, because of the degenerative disc disease, and I can't even put that Biodisc in him because they won't pay for that either.
Oh my God.
So all the best stuff that I have in my office, these stupid insurance companies, back to this lady. She was like, if you think I'm going to change my insurance, you can forget about it, Dr. Jasper. I was like, whoa, how do you respond to that? It's like, how do I not get pissed off at people like that? It's her husband. And all she has to do, I'll be paying an extra $200 a month. Extra $200 a month. I said, okay, Mr. So-and-so, get used to your pain.
Yeah.
Get used to your pain. And she was like, I never had a problem until now. I said, well, you're lucky that it's just your husband's back and not you with some kind of terminal illness that you need a special medication that'll keep you alive. And your insurance company says, no, it's experimental. We're not going to do it. And then you die.
Right.
Right. Then you
I mean,
die.
even
I
if
didn't
she,
say that to her, but
even if she was the one suffering pain, believe me, it would be a completely different story then.
well, who knows? I mean,
Yeah.
you know, and I was 2 times it happened within a couple days. The wife did not want to change because, you know, who knows?
Yeah.
Maybe she didn't like him anymore. I don't know. Maybe it's
Were they seniors?
oh yeah.
Yeah.
Yeah,
They get set in their ways, and then that's that. They don't want to learn a
that's
different.
the minority of them. Most of them, if they got the pain, they'll switch.
Yeah.
They could switch. It's a myth saying that you can't switch your insurance companies. Oh no, I can't switch because this is given to me my pension and my retirement package, and they no way I could. You could. I thought it was like that too because I listen to these patients, but we've done the studies and we've done research and we can do it and we've accomplished it.
Right.
You do it all online, and all of a sudden, the Medicare card comes in the mail 2 weeks later. Now you can have the procedure. Simple stuff.
Yeah.
Some people have to pay a little extra money because some of these advantage programs, the state, they don't want to pay much money, so they pay. They get a one that they don't have to pay much money into, and then at the end of the day, they don't pay for anything. So that's why it's cheap.
Yeah.
Is Barbara Schneider coming in?
No, not today. I was surprised because I thought 100% she'd be coming in.
Yeah. So so right now I'm studying very, very hard for my instrument rating for flying airplanes.
Yeah.
I've been flying airplanes since 1987, but I've been flying them visual flight rules, which means that you have to have at least like 1 mile, like you have to fly within only in good weather, basically. Let's make it simple.
Right.
You got to fly in good weather, but if
With clear visibility.
Clear visibility up to 3 miles visibility, 5 miles visibility, or 1,000 feet ceiling, or 3,000.
So you can see where you're going.
Yeah, you have to be able to see where you're going. You could fly above clouds, but the only way you can get to it, you got to go. It's got to be clear, and then your destination has to be clear. So you can fly above clouds, but you got to worry. What if the engine goes out? So you can fly safely. In fact, I've been flying it since 1987.
Right.
And then,
so is the instrument training then where you can fly the plane without the visual? Is that what that means?
Is you're legally able to fly an airplane,
right?
And hopefully also proficiently could fly an airplane in clouds. Strictly by the instruments on your dashboard.
That's good. Yeah, that's amazing.
And not have to look, because you look outside the windscreen, the window, and all you see is gray.
Right.
It's like somebody painted the inside of your windshield gray. So you see nothing. You have no outside vision. It's all strictly by, and I've been doing this, simulated and some real actual instrument flying. I the last one I did was actual was last week. I flew into it was called what was the name of it? It was up near Lake Wallapalpack, Cherry Ridge Airport, Lake Wallapalpack. Not a long runway, but it's long enough for these little airplanes to get in. But we flew in there, and you cannot land. In other words, each airport has an approach, and when it has an approach, it has a minimum. So if it goes, that had to be maybe 400 feet, let's say. So if you can't see the runway when you get to 400 feet, you got to do what they call a misapproach.
Right.
And what I was intimidated because I'm a student now. I'm just a student. I'm not proficient enough yet. And that's why I had an instructor with me.
Right.
And I'm coming in, and he was like, I got to set a minimum. I said, we're at minimums. Now we got to do a go around. But the fact was, I was coming in between mountains. Talk about pucker power. You know what that means?
Yeah, I get
pucker
it.
Power. Now, this is where they say you got to trust your instruments.
Right.
Got to trust your instruments. And in the meantime, you're like thinking, I hope these instruments are good. So I'm not to the point yet where I can trust my instruments 100%, but you got to.
Yeah.
Because there's a lot of redundancy there. You got different, when I say redundancy, you have different instruments that tell you to back the other instrument up to tell you that you're in this position. This one tells you, and you look at the other and say, yep, that instrument is correct. And you look at it, yep, that instrument's correct. So there's so much redundancy in there that you got to trust your instruments.
Yeah.
And you can't go off course. You got to stay exactly within like 0.3 miles of your,
destination,
horizontal.
Oh yeah.
And also your vertical.
Right.
You got to be like within less than 100 feet. Otherwise, you can hit an obstruction.
Right.
So you keep it. You got to be good. And I was very intimidated coming down.
I was going to ask you, like, what's your progression now with this?
Well, I mean, I'm almost ready.
Yeah.
I'm almost ready. I'm getting very close. But the fact that I lost my all my credentials, I lost my passport, I lost my wallet, I lost which had, my pilot's license in it, and my driver's license in it, all my credit cards, everything. I lost it. I'm in the process of getting all that, and I can't get my passport yet, and my pilot's license. I paid for it to send it, and it was like could take up to 45 days to receive it. What are you talking about? He said we mailed it out on the 11th of July. Yeah, bullshit.
You didn't tell me about this.
Yeah, 11th of July, and it's like I don't know, Iowa or something. But how long does it take for something in general mail, U.S. Postal Services, to get from California to here? 3 days at the most.
3 days. I always say that. There's no reason in this day and age
and they're telling
that
me
you can't get what you need in 3 days.
And they sent me that with an email, right?
Yeah.
And I emailed them back. I said, listen, I find it hard to believe that you think it takes up to 45 days through the U.S. mail.
Right.
I said, that's unacceptable. If you say that I said, this is an excuse that you haven't mailed it yet. And you said to me in the email, you mailed it. So I probably pissed them off. Now they're just not going to mail it to me.
Oh my God.
But anyway, that's what's going on.
Where'd you lose it?
Well, when I flew out to an accelerated course in South Carolina, and the weather wasn't good. The planes weren't running good. So basically, accelerated course supposed to have like 8 hours a day of simulated flying and ground school. Right. I hardly had anything, maybe more ground school. So I wasn't prepared to take the test. It was going to be a check ride with a DPE, designated pilot examiner, and they do like an hour, 2 hours of oral examination. They ask you questions, and then you go fly for a couple of hours and you do approaches. Well, I wasn't prepared. So I had to bring my passport. I had to bring all my credentials, and they had to, because I had to present it to them, right? Well, I got this new man purse. Rosalind got me, and I'm not used to it,
It was like a fanny pack or something?
Yeah, it was like a fanny pack.
Yeah.
So I put all my stuff in there, and I had a carry-on. And I put them both up on top of the thing, and I'm first class, first row. And some ladies, we landed. We just pulled up. They didn't open the door. Some lady screaming at me, "You got to get out of my way! I'm gonna miss my plane. Get out of my way! We got to miss my."
Oh.
And I'm already trying to get my heavy carry-on down. So wait a minute, they didn't even open up the door. They're gonna open up the door any second. Get out of my way! So I pulled that thing down, right, and I went like that, put it down. And she's pushing me. I was like, Jesus Christ, right? That distraction, I completely forgot my little fanny pack. And I left. Guess what? They never found it. It was like $500 of cash in there, too.
Yeah, that's why they didn't find it.
Well, I mean, take the cash and just put it in the mail,
They
for God's sake.
They don't do that.
They threw it in the garbage probably because they never found it. Or it's such a small bag in the back, it's deep in there, it might be still sitting in there.
Jesus.
You can't talk to anybody. It's all computer.
Yeah.
The emails. You can't say, please check that and let me know if oh, we're looking. We'll let you know.
This automated bullshit.
Can't talk to anybody.
Yeah. It's not a an advantage in our society. It's a disadvantage is what it is.
Compression fractures.
Compression fractures. Yeah. That I am absolutely.
What is amazing to me
Yeah.
is I had a patient that came to my office the other day with a compression fracture for like 2 months, went to her doctor, so bad they went to the emergency room, and all I did was give her pain medication and put a brace on her. And then she must have heard one of our podcasts or sometimes I got on the radio talking about compression fracture. The compression fracture is when they break this part of the spine.
vertebral body.
They break that. And it crunches and it hurts. You can't breathe. You can't cough.
Yeah.
You can't sneeze. You can't lean on it. You can't twist. Basically, you're in severe pain until it heals up. And it could take anywhere from 3 months to more than a year to heal up.
Yeah. Literally, this is what we used to call breaking your back, right?
Well, yeah. I mean, that we could call it that. But, you would think that would be more like, spinal cord injury, stuff like that. But it's really, you break your back. That's what the layman terms is. But it's a compression fracture.
Gotcha.
And I can fix that in a short period of time.
A short period of time, yeah.
And 98% of people that get off the table and stand up are pain free
Immediately.
Yeah. So all of that stuff goes away.
Yeah.
I've had some people that get off the table and they have just as much pain. I said, well, let's see what happens in a couple of days. And in a couple of days, it goes away. But some people, it doesn't go away. Guess what? They have another fracture that they must have fractured between the time where they got the MRI and I fixed it. So they actually came in with another fracture.
Right.
And it's very hard to tell unless it's a major fracture through just a fluoroscopic X-ray. You got to look under an MRI with a special type of stir technique, which lights up like a light bulb, and you can see it.
Right.
Like I had that lady never even had an MRI. She had an X-ray that suggests compression fracture. Never had an X-ray really before to compare it. And she said, what did she say? She lifted something up and felt the pop, and then it was severe pain. I mean, that's classical. How it happens. She has osteoporosis. Worse insult to injury is like somebody breaks their back with a minor movement without lifting anything heavy. What does that tell anybody? Even a layperson. They got osteoporosis or they have osteopenia. Or they got cancer that has infiltrated. It's something that should be followed up. She went to her primary physician. Now, this is many primary physicians are out there. Please, send them for a bone density to see if they have osteoporosis or if they have osteopenia or if they got some strange in the spine. Even the bone density would let you know that there's something not supposed to be there, and it lights up. It lights up with the what happens to bone density, you can see stuff, but it tells you whether you have osteoporosis or osteopenia.
We can do that, right?
Well, no, we got rid of that machine. But what it is you could put them on medication to prevent it from happening. She's not on any medication. And this was like 2 or 3 months ago. So I don't know what these doctors are thinking. I sent her for it, and she goes, well, who's going to give me the medicine? I said, your doctor who missed the diagnosis, because that's what they're supposed to do. I don't give medication for that. I have no time for that.
Yeah.
You know, I'm in the operating room taking care of patients. I don't have time to write prescriptions. You know, I write prescriptions for MRIs and stuff like that. But anyway, and another thing, if you suspect, you know, don't even do an X-ray unless their insurance company make you do an X-ray, but just send them right away for an MRI with a stir technique.
Yeah.
And then you can figure that out. What time is it? Well, it's 11:06.
Yeah, it is.
We're going overboard here.
Yeah, we are.
Well, we started a little bit late, but you know, if anybody's interested in getting their back fixed, or, you know, we do joints, we do PRP, regenerative medicine, stem cell type stuff. We do all of that stuff also. We do knee injections, shoulder injections, rotator cuff injections, tendonitis, tendons, torn muscles, stuff like that, Achilles tendon. And we do the minimally invasive spine. We do epidurals. Epidurals are what I do to diagnose the problem. If it doesn't work, then we go to the next step. You can call us at 732-262-0700. And we're at 74 Brick Boulevard, Brick, New Jersey. And if you're listening in another country, I've had plenty of people come to see me.
Oh, yeah.
In another state.
We had somebody in Washington State, right?
In Washington State, he wants to come and get the Viadisc.
It's the other side of the country for us.
He watched our podcast, and then he saw we had a great testimonial. In fact, that guy was talking about yesterday, the one that was like 100% pain-free from the Viadisc.
Yeah, yeah.
Philip did a video on him.
Did he?
But he didn't send it to me.
He's got to send it to me, too.
Yeah, we got to put it on. He said, great video.
All
Nice guy. All right. Thank you very much. Give us a call, and we'll talk to you next time we're on the air.
That's right.
This will be on the radio show tomorrow
morning
at 7 o'clock.
7 o'clock.
At WOBM.
Yeah. All right. For more information about Dr. Gabriele Jasper and all the wonderful things we talk about on our show, please go to jaspermd.com. And like the doc said, if you want to make an appointment with Dr. Jasper, dial 732-262-0700.